I think I have share options, so I can share my screen from here. Is it
Yes,
okay?
yes, you can. Yes,
If you want, you can try.
So please share the slides. Good evening, all of you. Welcome to this 250th landmark edition of Thursday Musings. Today we'll be learning about communication skills, how to improve them, about OSCEs in psychiatry. So what happens is the meeting is being recorded. The recording will be put on YouTube viewing for later on. Everyone will be on the mute mode. Only the panelists can unmute themselves. The presentation will be around 30, 40, 45 minutes. After that, questions will be there. Questions will be taken up by the moderators and chairpersons to the speaker. So I think, yes, that is all from my side. Next slide, please. And over to Dr. Tufan Pati, sir, who is the chairman of this program. Sir, over to you.
Thank you, Dr. Alim. Thank you, everybody, and welcome everyone to this 250th episode of Thursday Musings. It's a landmark episode of this webinar series. Next slide, please. I have the pleasure to acknowledge the vibrant moderators with us, Dr. Amrit Patajoshi, Dr. Alim Siddiqui, Dr. Sobit Gar, and Dr. Bisal Chabra. Welcome, everybody. And Dr. Sabita Malhotra, is Madam over here? She is the chairperson.
Madam she has some medical issues, so she'll not be able to join.
Okay. In absentia, I welcome, appreciate the consent of Dr. Savita Malhotra, President IPS, to be the chairperson. Her major achievement, clinical teaching and research experience of 42 years, more than 4 decades at PGH Chandigarh. Special interest areas have in child psychiatry, telepsychiatry, tobacco cessation, and psychotherapy. Honors, International Contribution Award by the International Association of Child and Adolescent Psychiatry and Allied Professionals. The American Academy of Child and Adolescent Psychiatry for outstanding contribution and global leadership in field of child psychiatry. Recipient of East Pulitzer Prize in 2022 and World Association for the Social Psychiatry. Past President of Asian Society for Child and Adolescent Psychiatry and Allied Professions. Past President IASP. Life President of Indian Association of Child and Adolescent Mental Health. Awards. Numerous academic awards including DLN Murthy Rao Oration by IPS, NND Oration by ASP, PP Oration by ISCAM, Dr. KL Garg Oration by NAMS, Bagadia Oration, Tilak Bhim Kaurai Oration by ICMR and others. Publications, authored and edited books, published numerous book chapters and research papers, hobbies, Urdu poetry, and traveling. Next, please. The other chairperson is Dr. Gautam Shah, past president of IPS, MD FRC from Edinburgh, is Director Clinic Brain Neuropsychiatric Institute at the Research Center, Barasat, Kolkata, Honorary Member World Psychiatric Association, Honorary General Secretary Asian Federation of Psychiatric Association, Immediate Past President SARC Psychiatric Federation, Past President Indian Psychiatric Society, Immediate Past President Indian Association of Geriatric Mental Health, Distinguished Fellow American Psychiatric Association, Honorary Member Psychiatric Association of Nepal, author of 4 books, publications 43, many national and international presentations. Welcome Dr. Gautam Shah and Dr. Sabita Malhotra in absence. Now I will request Dr. Gautam Shah to
Dr. T.S. is also.
And Dr. T.S. Rao, who is there with us in this meeting as a chair. Dr. T. Satyanarayana Rao, incoming president of IPS, all the presidents today, and vice president cum president-elect of IPS, professor emeritus in psychiatry and child, chief coordinator in psychosexual medicine, Department of Psychiatry, JSS Medical College, Mysore, past general secretary of Indian Psychiatric Society, editor Journal of Psychosexual Health, president-elect South Asian Societies of Sexual Medicine, affiliated to International Society of Sexual Medicine, formerly president of Indian Association of Geriatric Mental Health, formerly editor of Indian Journal of Psychiatry, co-chair Psychiatry and Human Sexual section of WPA, publications, research and review papers 362, books and book chapters 28, awards and orations including Marfatia, Dale and Murthy Rao, C.V. Raman Distinguished Scientist and Acharya Award 26, President, Karnataka Sexual Sciences and Academy. Welcome, Dr. Rao. With this, I request Dr. Gautam Shah to please introduce the speaker and both the luminaries to throw light on the topic of discussion, and then Dr. Pratap to carry on presentations. Over to Dr. Gautam. Dr. Gautam Shah.
Good evening, ladies and gentlemen. At the outset, I must mention it is the 250th I can say, academic program organized by Team Thursday Music. I don't know any other organization, any other team can do more than this or not. It may be come in the Guinness Book of World Records. Consistently, persistently, with the dedication, sincerity by the team Thursday Music and the Indian Psychiatric Society Odisha branch has done wonderful job. In fact, if you ask me, the people associated with this, Dr. Tufan Poti, Dr. Amrit Pattajoshi, Dr. Alim Siddiqui, Dr. Bishal Chabra, and Dr. Sabit Garg, and all other people who are involved in this team, is really hats up to you all and kudos to you. Right now, I am introducing Dr. M.C. Pratap, who is a senior consultant psychiatrist, and he is the founder and chairman of Saditya Hospital, which is 150-bedded tertiary care psychiatric hospital based in Palaram, Chennai, and he has treated more than 10,000 cases in the last 10 years. He runs a successful revision course for the MRC Psychiatry in UK for 20 years. He is the founder and director of SPMM course for the MRC Psychiatry in UK. His special interest is to raise public and professional awareness regarding the mental health. And he runs a famous YouTube channel for the last 5 years, Psychiatrist Pratap, with a large number of followers. And he is also the author of the self-motivational non-fiction book, The Golden Nuggets for Success and Happiness, published recently. He is a gold medalist and was the best outgoing student of the medical college. And he received the Best Doctor Award from IMA in 2020 and the Star Doctor Award by the Tamil Nadu Medical Council in 2021 and Healthcare Excellence Award in 2023. He was passionate to start good quality of psychiatric care service in India and came back to India after working in UK for 14 years. Though his hospital is able to offer a lot of new psychiatric services and subspecialties in psychiatry, which are now available in India. So if we read all the things, we cannot stop the quality Dr. C. Pratap has. In fact, we are lucky enough to have a speaker like him. Today morning, I just talked to Dr. Abir Mukherjee. You know that he is a colleague of Dr. C. Pratap. He praised like anything, and he was most probably the co-colleague. He was the colleague of him and was the co-faculty of his institution. I mean, his course. So, and number one, the topic today we have selected is not only for us, it is also very important, especially those who are doing PGs and those who are in the early career psychiatrists. The purpose of OSCE in psychiatry, you know, that is basically to assess the clinical competence in assessment, diagnosis, management, and the communication skills. I'm not going to in detail and I hope that people are waiting to listen him. And I hand over my mic to my co-author, one of the most respected people in our fraternity, the Vice President of Indian Psychiatric Society, none other than Professor T.S.S. Rao. Sir, Dada, please.
Thank you so much. Thank you so much.
Yes.
At the outset, I'm really grateful for the invite to join this particular program as co-chair. So also, I would like to place on record all the sentiments expressed by Dr. Gautam Saha, our past president, related to this 250th program, a real milestone, and it is doing a great job. And congratulations to each one of you for everybody could see it's in Indian Journal of Psychiatry, the way its origin, progress, and future. I'm more than sure that very soon we will be 300th and much more, in fact, in the coming days. There's one aspect of it. Coming to the education in general, particularly the medical education, since NMC came, CBME, OSCEs are some of the very important aspects. We as teachers and examiners, we have felt at different centers, different approaches actually people are following. And there is a great work that has happened in this particular field, that how OSCEs should happen and how actually it should be interpreted. So that means one of the basic important aspect is actually the communication aspect between the student and the teacher, and how an evaluation assessment can be done. I am more than certain that everybody is aware of, but emphasis is actually missing. And I think from that particular angle, we are more than sure that today's points will actually make us aware, educate ourselves, and enlighten as well as how one should go about it. Already Gautam Saha mentioned even about OSCEs actually that are actually there in the current this thing and its relevance. And I would be extremely happy to request the speaker to go ahead, and we'll be there later part for the discussion. Thank you very much, everyone, for this wonderful opportunity you have provided. Thank you.
Hello, good evening, everyone. A big thank you to Dr. Gautam Saha for giving a nice introduction about myself. And I would like to thank and congratulate all the organizers of the Thursday Musings. And it's a real honor to present on the 250th edition of this good academic program. So I'll make a start now.
Yes, sir, please.
So the topic, as it was mentioned before, is OSCEs in psychiatry and improving communication skills. So in this particular lecture, I wanted to give a brief overview of what OSCE exams are. But at the same time, I also wanted to emphasize on how we can improve the communication skills with our patients in our day-to-day practice. So both topics will be covered simultaneously. This is just a copy of the book which was published last month. It's a self-motivational book which I have written with 42 chapters. So let's discuss about the OSCEs and the communication skills. So I'm going to talk about different interview skills which we all have to inherit as psychiatrists. Communication skills are really important for all medical specialties, but it is even more very highly important for people working in the field of psychiatry. When I first came to the India to practice, which was in 2015, many patients actually told me that they gave a positive feedback that, doctor, you're interviewing us very well. You're able to explain things really well. And we really admire how you're doing it. So looking back, I realized that that particular skill which I have inherited was due to me involved in taking OSCE exams and also examining in OSCE exams and teaching OSCEs for more than 20 years for trainees throughout the world. Through my course, more than 10,000 people have obtained MRC Psych, and I have trainees from more than 100 countries of the world. So I'll just give you what OSCEs are. We'll start with the basics. The word OSCE stands for Objective Structured Clinical Examination. So it's a modern type of examination which is often used for assessment in healthcare disciplines. In OSCEs, clinical skills, mainly practical skills, are tested rather than pure theoretical knowledge. We all take theoretical papers like paper A, paper B, part 1, part 2, etc. In all those papers, theoretical knowledges has already been tested. So the aim of OSCEs is to test the clinical skills and practical skills. So through OSCEs, we can assess a cross-section of the clinical knowledge as well as practical skills. Many of them are generic skills, developing rapport with the patient, expressing empathy for the patient's difficulties, making the communication pathway easier, making them really understand what they're going through. All these are assessed cross-sectionally during the OSCE type of exams. Why is OSCE becoming so important now? So OSCE became more famous after the year 2000. So it's a formative assessment tool for undergraduate medical education in most of the Western countries, especially United Kingdom and US medical schools. It has become a performance-based assessment tool for testing the minimum accepted standards of students who are taking the exit examinations during the undergraduate years in most of the Western countries. It is also becoming a high-stakes assessment tool in postgraduate psychiatry, especially in most of the Royal Colleges. The Royal College in the UK has changed the OSCE name into CASC, which is called as Clinical Assessments of Skills and Competencies, which is the same as the OSCEs. And again, in France-up exams also, we have OSCEs. So most of these Western countries, they use OSCE methods to assess postgraduates for the final examinations. It is also a tool for the assessment of graduates seeking high-stakes licensure and certification to practice medicine. For example, if you want to travel from India to any Western countries, you have to take these exams, OSCE exams, before you get the license. In my case, I have to take the exam to get the license for the General Medical Council in the UK. And currently, in many Western countries, OSCEs are also used to give feedback in their workplace. So workplace-based assessments are done and feedbacks are given. So it's become increasingly important. And I believe that in few years down the line, even in Indian medical schools, postgraduate schools, it'll grow into its, in terms of testing. So OSCEs in psychiatry. So the word OSCE is, first part is objective. So it's an objective assessment of skills, and every student gets the same patient with same clinical scenario. So if there are 200 patients, 200 candidates taking the examination, all of them will get the same patient with same clinical scenario. This helps to minimize subjectivity, and there will be objective assessment of the skills. The second letter is S, structured. So several skills are tested in a structured manner and evaluated on the same criteria. There is a time limit for each station, and they are judged by independent examiners using the same preset standards. The standards are already set by the examiners, and they use the same standards to judge the candidates. Third, C stands for clinical. So multiple stations are tested, and we can test different areas of clinical competence and practical skills. For example, history taking, mental state examination, exploring psychopathology in detail, assessing insight. So different areas can be tested, different clinical competencies can be cross-sectionally assessed. And lastly, the examinations are standardized. The tasks, scenarios, and assessment criteria are all standardized. Therefore, it ensures fairness as well as comparability. That's why OSCE exams are also very famous. So this is just a cubicle which I took from the UK exams. So this is a circuit of how the OSCE exams. So as you can see, there will be like 10 booths or 12 booths or 16 booths, and different areas, clinical areas will be tested in each booth. Traditionally, we had long cases. So long cases are replaced by an OSCE. The problem with long cases, you interview one patient for 45 minutes or 1 hour. Then you present the history and a mental state examination to a couple of examiners. But the problem is there is huge variation in terms of the complexity of the case. Sometimes you may get a very complex case. Sometimes you may get a patient who may be a poor historian. Sometimes you may get very tough examiners. So all these subjectivity are ruled out. So in long cases, the exam was never going to be seen as very fair. So sometimes if you're lucky, you're more likely to pass. But if you get any complexities in terms of the patient being difficult or examiner being difficult or the case being too complex, then you're likely to fail. But in terms of OSCEs, you are assessed with different sets of stations. For example, circuit 8 stations to 16 stations. So in the MRC examination, there are 16 stations. And candidates are expected to pass 12 out of 16 stations. The reason is because the candidate may become tired by doing one station after the other. They may not perform well in one station. Sometimes the examiner may be quite difficult, who is not keen to pass that many candidates. Sometimes the actors may be difficult. They may not give the information very well. Sometimes it may be very brand new station, which the candidate wouldn't have practiced. So there is some leeway. And if you practice 12 out of 16, you're more likely to pass. So similarly, in different countries, they expect you to pass almost 75% of the total stations and not all of them. So each OSCE circuit, there will be a candidate, a role player, and also an examiner judging. Normally, in the OSCE circuits, you will have reading time, 1 minute reading time, or sometimes 2 minutes reading time, or in management stations, there will be 4 minutes reading time. So the college also calls this as thinking time. So while you're reading, after you're finished reading, if you have more time, you can think about what you're going to perform and how you're going to perform that station. Then performance time is usually 6 minutes, or sometimes 7 minutes, or sometimes 10 minutes, depends upon the stations. Usually there'll be a warning bell at the end of the, before the last minute. For example, if it's a 7-minute station, there'll be a warning bell at the end of 6 minutes. Then at the end of 7 minutes, the final bell will ring and you have to stop. Then you'll move to the next booth. That is how it works. Now, in all these OSCE stations, the real patients are replaced by actors. Okay? These are people who are professionals. They are actually briefed already and coached to simulate real cases. For example, I have more than 60 to 80 professional role players based in London. So they're all briefed and coached by me to simulate real cases. And the script is the same for all the candidates. So if one role player is performing a task, the same script will be performed by the role player for all the candidates. Okay. So it's much easier for the examiners to compare the candidates across the board. So the examiner may be examining 10, 20 people. So they examine the same scenario, but across the board. And it is easy for them to judge who can be passed, who can be failed, etc. And they also grade candidates from A to E according to the Likert scale, or A to F on a variety of different areas. This is a sample of the mark sheet, which is used in the Royal College exams. So if you look at the overall judgment, you're expected to get either excellent pass, or borderline pass. So after you fully perform the station, at the end of 7 minutes or 10 minutes, the examiners will make an overall judgment if you have done the practical skill, clinical skill well or not. So if you do that, you get either of the three. But if your performance is below average, you will get borderline fail or severe fail. That is how it works. Other than that, in each task, there will be competency domains. There are different elements that you will be asked to elicit with the role player. For example, in this particular scenario, the patient had a relapse of psychosis. They had schizophrenia and they relapsed. So the task was eliciting the abnormal psychopathology, the auditory hallucinations and delusions that he's currently exhibiting. And the second part of the station was identifying the reasons for relapse. So in this case, the patient was non-compliant and he was also taking drugs. So the examiners expect you to identify the possible reasons for relapse of the psychosis. So there are different domains covered. The first half of the domain is about eliciting abnormal psychopathology. The second part of the different domains are about identifying different reasons, possible reasons for relapse of psychosis. This is how they mark. So while you're performing, they will try to mark, but in the end, you'll be given an overall judgment. So the full advantage of OSCEs is multiple skill sets can be tested, which allows us to test broader content and wide domain coverage. It decreases bias because they're getting the same stations, same scenarios, same kind of marking template. The template is not going to be changed. The examiner will have the same template to mark. Therefore, it reduces the variability of examination. And lastly, practicability. To get real patients, it's very difficult, but we can train and coach actors who are simulated patients. And if they provide script, they can act like real patients, decreasing the real need for real patients during the examinations. In terms of range of stations, they usually test patients from any setting. It could be community, it could be outpatient setting, it could be inpatient setting, home environment, any settings. And any age group can be tested, from childhood, adolescent, normal adult, elderly patients, and any developmental ability. And basically, most of the guidelines says that they check for any psychiatric disorder listed in ICD-10 or DSM-4. For example, in the last college exam in the UK, they kept a new station, which was about premenstrual dysphoric disorder, which is quite relatively new. So they can test any psychiatric disorder, which is listed in ICD and DSM. So specialty area tested. So while you're going through 12 stations or 14 stations or n number of stations in psychiatry, they're able to assess you in different areas: general adult, old age, child adolescent, intellectual disability, forensic psychiatry, substance misuse, psychotherapy, specialty areas like eating disorders, perinatal psychiatry. So from all these areas, you will get stations tested in the real exam. So a candidate who is doing 3 years of postgraduate should have gone through all these things, and they should be able to prove their clinical competencies and skills in different subspecialties in psychiatry. So history taking is very, very commonly tested. They sometimes ask for one particular element of history taking, and depth of coverage is usually tested. For example, you may be asked to elicit presenting complaint in detail and past psychiatric history of the patient, physical health history of the patient, to take very detailed medical history, the developmental history of patients, particularly in child and adolescent cases, personal and social history of the patients, and obtaining collateral history from the family members, carers, relatives, friends, etc. All these areas are covered in history taking, and history taking is given a lot of importance in the OSCE circuits. The other kinds of skills which are tested include mental state examination. They may keep a patient who is very psychotic with lots of abnormal psychopathology. They may keep patients who have no psychosis, but normal mental state presenting in the clinic just for a review. Cognitive examination is regularly tested. Out of the stations, one station is a definite cognitive examination station. Capacity assessments are tested. Capacity assessments for medical decisions, capacity assessment for financial decisions, capacity assessment for social care decisions. So one station will be on capacity assessments. risk assessment, risk for deliberate self-harm, suicide, risk assessment for violence, risk assessment for sexual offenses, etc. There'll be one station on risk assessment. And lastly, physical examinations are mandatory. Okay? We'll go through this later. So these are all definitively tested in various different stations that you go through in the OSCE exams. Range of further skills recently introduced by many colleges is risk management. So the role of psychiatrists is not just to do a risk assessment, but we also have the duty of care, even in real life, in terms of safety planning, as well as risk management for patients with deliberate self-harm, history of violence, suicidal patients, etc. So they expect you to prepare a safety planning and risk management plan for patients. They like you to do case formulation. So after taking history, they want you to do a case formulation and present it to the examiners. Then etiological factors. They expect you to elicit etiological factors in detail. In some stations, you have to prepare a holistic management plan, incorporating the biopsychosocial model, the biological treatments and psychosocial models of treatment for each cases. And then discussions about different procedures like ECT, transcranial magnetic stimulation, different types of medications like lithium, clozapine, etc. And ethical dilemmas are also tested. So all these will be covered in the total 12 to 16 stations from different areas of psychiatry. Overall, if you ask me about OSCEs, it's very much like taking a driving test. You will need to demonstrate your skills in a rather regimented and obvious and structured manner. If you've taken driving test in the UK or Middle East or Western countries, you know how hard it is. It's very structured and regimented. So OSCE exams are very similar to that. But if you prepare well, if you practice them well, you're more likely to pass them. Okay? So my first advice is I always tell people, try to form very good practice groups. Any exams, you have to have a study group. Try to form small practice groups with 3 or 4 people in number. Okay? And try to shoot videos and be your own judge. You can try to talk in front of cameras and pretend like taking history or doing a mental state examination. You can shoot videos with your colleagues and then see how the videos look like, how your body language is, how you're talking, etc. And try to role play. You have to role play like a candidate. You have to role play like a patient, so you can understand how the patient would feel when you were put in that situation. Then you can also role play like an examiner. You can mark another 2 people doing it, so that from examiner's perspective, you know when to pass and when to fail the candidate. Okay. So forming practice groups are really important. Okay. And I advise people to practice with their colleagues, with their junior colleagues, senior colleagues. Sometimes patients are also cooperative. So you can practice with all these people. The more you practice, you're more likely to pass these kind of exams. Many people take the theory exams, they study on their own, but then they wanted to do the OSCEs also on their own, but it doesn't work that way. Okay. So as long as you have a good study group and a good practice group, you're more likely to pass. Okay. Imagine learning some tennis skills or swimming skills. You can't just learn them by just reading books about the game. You need to practice all those skills. And you should take your new learning into the real world and then apply it. So these things have actually helped. Once you take the OSCE exam, you will know how good you become in terms of communicating with your patients, how much you can improve on your interview skills. Now, I'll touch a bit upon how to interview the patient. A lot of these are basic skills which you may already know, but I'm just going to give a quick revision of what is required when you interview a patient. So it's not just helpful for the OSCE exams. It'll be very helpful in real life practice. And some of the skills which I'm using, I've just put it in the slide. Okay. So generally, when you do the OSCE stations, you have to read the question properly. You have to read the question properly. You have to stick to the instructions because you're not taking a full case. If the task says take a history, you have to take a history. If it says perform a mental state examination, you do a mental state examination. If the task says do a risk assessment, you do that. So what has been asked, you need to read it properly and then perform the task. There's a very common joke people say, if a monkey asks for a banana, then you give monkeys. You give banana. You don't give apple. If you give apple to a starving monkey which wants banana, then monkey is going to become very unhappy. Similarly, if you do the wrong task, the examiner is not going to be happy. You're more likely to fail the station. So try to stick to the instructions and read the question properly. I've just given one recent task which was elicited in one of the exams. The task is you are working with the community mental health team for older people, and you're on a home visit to see Mr. Ken Smith, an 83-year-old retired post officer who his general practitioner has referred due to concerns about his low mood. Mr. Smith is a primary caregiver for his wife, Eve, who was diagnosed with vascular dementia a year ago. He has had routine blood testing, which has returned normal results. He has a history of arthritis. Now the question is, take a relevant history of presenting symptoms and perform a risk assessment. So you have 7 minutes or 10 minutes for the station. You have two tasks. One is take a relevant history of presenting symptoms, and you have to perform a risk assessment. So you have to read the question and then focus on your task. Sometimes multiple tasks are possible. Like in this question, you've got two tasks, history taking as well as risk assessment. So these days, most of the colleges check multiple, they keep multiple tasks to be checked. Try to use a notepad or notes and try to make note of patient's age or gender. Because sometimes when you talk to the patient, even in real life, it is important to get the age, gender, name of the person well. That will make us to make a really good start. If you make mistakes with the name, then it won't give a good impression. Okay? So try to make notes of these things. Sometimes in most of the stations, if you're unable to complete reading the task, a copy of the task will be displayed inside. The examiner will also have a copy so you can check. But try to make sure that you do the right task and focus on it. So using a small notepad, you can write down the instructions. For example, in this case, Ken Smith, that is an 83-year-old man. His wife's name is Eve Smith, and she has got vascular dementia. Now, my task is to take a relevant history of presenting symptoms for Mr. Ken Smith and perform a risk assessment on him. Okay. So you get the clarity in your mind, then you go enter the station, then you start performing your task. Useful hack. One important tip is to read the last part of the question first. Sometimes the tasks can be quite lengthy. So you can always read the last part of the question. Be clear about what you're being asked to do before you read the entire case synopsis. When you do this, you will always know your task if your reading time outside the station runs out. Okay. Even if there's less reading time, you will know exactly what task has to be elicited. Therefore, you can focus on aspects of the case more relevant to the task when you're reading through it. Okay. That's a very useful hack. So in this case, read the last part, understand what has been, what they're going to test, and then read the case synopsis. So read the question properly. So some candidates tend to convince the examiner that they have not read the question by asking completely wrong things. For example, let me say the task is about discussing pharmacological augmentation strategies for depression. I've noticed people are wasting time taking a lot of history about depressive symptoms. You know very well the patient has got depression, but your role is to talk about pharmacological augmentation strategies. But instead, people waste time taking history of depressive symptoms. They are not going to get any extra marks for that. Or sometimes people can discuss things like ECT. Okay. The task clearly states pharmacological strategies. So you have to discuss about the pharmacological management in that station. Similarly, you have to read each and every word and then follow the instructions. On entering the booth, so you've read the station, you read the scenario outside the station, then you enter the booth. On entering the booth, you have to give your candidate number to the examiner. They'll check for it. Then you shake hands if volunteered, but it should be quick and firm. Then give them a brief smile. The examiners are also human beings, so just give them a brief smile. Okay. then you focus on the patient. When you start with the patient, always address using their surnames. People expect respect. Okay, so use their surnames first. For example, if it is Arun Agarwal, I would just say Mr. Agarwal first. If they tell you, I don't mind you calling me calling me Arun, then it's fine. But addressing using their surnames is really important. It makes sure that the patient feels that they are respected by the doctor. Then you sit down. First, sit down before introducing yourself, unless the patient is already standing up. Okay? And when you sit down, don't sit too close to the patient and try to maintain an appropriate and professional distance between you. If your knees touch the patient, it means you're too close. It can be quite intimidating for the patient. So you should not sit too close, but try to maintain some professional distance between you. Suddenly, when the interview is happening, if the patient gets up, we can also rise shortly after them. Okay? But we can offer comforting words like, let's sit down and talk about it. You can tell me what's been going on. And then sit down yourself. Okay? If they don't sit down immediately, remain seated and maintain an eye contact with the patient by adopting a submissive posture. Okay? This makes you appear much less threatening to them. So you don't have to stand up and just face the patient. You can still sit down, remain seated, but maintain eye contact and ask them to take their seat. It makes them appear less threatening to the patient. So introducing yourself is very important. Introduce yourself at every station. So if you're doing 12 stations, you have to introduce in all the 12 stations. Every station is a new station. You have a new patient or a new role player, and you need to say hello to each one of them. Okay? And new examiner. So you have to display your number as well. So try to create a brief introduction that you repeat with minimal variation. So you always have to start well. So you have to prepare some good introduction, a brief introduction with slight variations from one station to the other. For example, good morning, I'm Dr. Pratap. I'm one of the doctors working with Dr. Patel. I've been asked to speak to you about the treatment you have been having for bipolar disorder, and I'll answer your questions as much possible. Okay. So this is how you start you introduce and start. You also have to check for the room layout, because our safety is also important. As you walk into the station, get into the habit of quickly assessing the room layout. You should try to aim to set it up as part of the first few seconds. Okay. You should try to sit at 90 degrees angle to each other. And if possible, if the patient is agitated or aggressive, you position yourself between the patient and the door. So if somebody is extremely violent or aggressive, then you have a means to leave the station. Okay. But it's very rare, but that is the expectation. Okay. So this is one of the photographs which I have taken from the teaching course that I run. So this is the role player. This is the candidate. And the booth is right here. So if there's a problem, they can leave the booth, but they should sit like this, maintaining some professional distance between each other. We can follow the same in our real practice too. Okay. Then you have to set the scene. So you should tell the patient what you're going to do, for how long you have to do it, and some of the points you intend to cover in the next 7 minutes. I'll give you another example. Good morning, I'm Dr. Pratap. I'm one of the doctors working with Dr. Patel, the consultant. I've been asked to speak to you about the treatments that you have been having for anxiety and depression. It appears as though your current antidepressants haven't been as effective as we had hoped. And therefore, Dr. Patel has asked me to speak to you about another treatment that we can try. I want to tell you a little bit about a drug called as lithium for the next 10 minutes. I will tell you a little bit more about what this drug is, why we use it for depression. I'll also explain what we can expect from treatment in terms of response from this medication. I will also discuss side effects and blood testing involved while you're taking this medication. Is that okay? So you're giving an introduction in the very beginning, telling them that you're going to talk about the new drug called as lithium, the effects, the therapeutic effects, the side effect profiles, the blood monitoring that will be required, and also answer other questions. So that will give a good introduction to start when you enter the station. Okay. The important thing is to develop good rapport. Even in my real practice, I try to develop good rapport with my patients. I try to maintain good eye contact with my patient, and the patient should feel that the doctor is confident and also enthusiastic, who wants to know more about myself. That same attitude should be displayed in your real exam. Okay. Body language. This is really important. We as psychiatrists, when we talk to our patients, we should not display signs of negative body language. Okay. So if you don't maintain good eye contact, that indicates lack of confidence in yourself. So maintain good eye contact with the patient. Arms folded across the chest. That is not the way to sit in front of the patient. That makes you look defensive and also disinterested. Okay. Head down. If you keep your head down all the time, it indicates low confidence level in you. Hand on the back of the neck. That signals that you wanted to end a conversation. You're tired or you're not really bothered about what they're talking. Okay. Sitting too far back in the chair. That indicates boredom and disinterest from the doctor. That is not a good message if you want to establish rapport. So it is important to avoid all these negative signals of negative body language. Okay. Similarly, non-verbal gestures. Negative non-verbal gestures to be avoided. So body posture, if you lean backwards, too relaxed, that means you're not focusing on what the patient is trying to say. Sitting close to the patient is not good. This can make them feel anxious and intimidating. Doctors yawning, chewing gums, that shows disinterest towards a patient. Repeatedly checking the phone or watch means you're in a rush to finish. Again, that won't leave a good impression. Okay. Tapping gestures, tapping the table and things like that, it makes the doctors look very anxious. So make sure that you don't display negative body signals and negative non-verbal gestures, both in practice as well as in the OSCE exams too. Okay. So what you should do is you should keep your head held up with nodding while the patient is talking. That signals attentiveness and means that you're really interested and curious to know the patient's story. And when you talk, there should be more energy in your voice. You need to speak loudly as well as clearly. The patient should understand what you're talking. Patient should be able to understand the information you're giving. And maintain a consistent, even pace. Sometimes people talk at a very fast pace. If you do that, the natural empathy and warmth will suffer. But sometimes people are very too slow in their pace. Again, that patient can get bored and they may lack focus. Therefore, try to speak at a consistent, even pace. Okay. So your body language should be well under control. So a good doctor should have a nice tone, calm manners, calm and composed, more animated with lots of facial expressions and in their voice, more warmth towards the patient, a brave and a smiling face. This is what they expect in the exams. This is what we should also do in our real life. Interview techniques. Let's quickly see the good important interview techniques relevant to our practice as well as these exams. Always start the interview with open-ended questions. Okay, that's the opening stage of the interview. It allows free narration by the patient. Okay, so you can start by saying that, I'll give you some examples. Tell me more about your memory problems. Could you describe what is recently bothering you? Can you give me some examples of your memory loss symptoms? What brought you to the clinic today? So these are all open questions. When you throw open questions, it allows free narration and the patient will also first open up and talk. So open questions are helpful to start in the beginning, but at some point you have to focus more. Sometimes patient can be over talkative and they can be extremely poor historians. Okay. They think something is important to them, but they give poor history. Okay. And having too much of open questions is not very time efficient. Sometimes it can lead to circumstantial elaborations. They'll go to all different areas which are not much relevant. So we should try to take control of the interview. How do you take control of the interview? You start with open questions, then move on to closed questions. Then we can lead the patient. Okay. So with closed questions, the intent of the question is very clear. And you get precise, focused answers. For example, you mentioned that there is a problem with your memory. Is this your short-term memory or long-term memory. You mentioned that you have some problems with your language. Can you give me some examples, specific examples, please? So when you ask more focused questions, the intention of the question is very clear for the patient, okay? And it can be highly time efficient, and we can try to cover different areas. Good diagnostic coverage can be done when you try to have good set of closed questions. So closed questions involves questions like what, when, where, how. These kind of questions have to be asked. So when you start the interview, start with open questions, then move to closed questions, asking all these things. In a lot of these questions, the answers can only be yes or no on most occasions. For example, did you sleep well last night? Yes or no. You have lost weight recently, haven't you? Yes or no. So you can dig and get more information that you want. Okay. Closed questions are avoided in the early parts of interview, as they can produce prescribed answers which are lacking in detail. So you should do it later. Okay. And you should also try to avoid it in highly suggestible patients. Sometimes if they're suggestible, they're going to say yes for a lot of questions. So you should try to avoid that in suggestible patients. So a good technique is to start with open questions, then move on to closed questions by the later part of the interview. Ideally, a good interview technique should have an appropriate mix of open and closed questions. That will be useful to rule out less likely symptoms. So you can focus on the diagnostic coverage of your set of symptoms and get the information. Next is repetition. So repetition involves repeating the exact words of the patient. Okay. So how does it help? It helps the patient to feel that the doctor is listening actively to what they are saying. For example, if the patient says, I was having bad dreams last night, I would ask them, so you were having bad dreams last night? So by repeating exact words of the patient, they feel that I'm actively listening. Okay. Sometimes you can repeat part of the phrase. Okay. That is what we call it as reinstatement. So you reinstate their phrases. That is also one way of establishing good rapport with the patient. Okay. Third important technique is clarification. You have to clarify. The doctor tries to get details from the patients about what the patient has already said. Okay. That shows that we are interested and curious in knowing more. Also, it helps us in avoiding misconceptions. For example, you said you're feeling depressed ever since you can remember. When do you feel most depressed? So when you ask that question, then you can clarify, okay, exactly from when the symptoms have started, and then ask further close questions to identify the progression of symptoms. So clarification is another important technique which you have to use. Next is summation, giving a summary, a short summary. So brief summarization of what the patient has said up to a point in the interview. For example, when you're talking to the patient after 2 or 3 minutes, a brief summation would really help. It helps the patient check if they've said what they really intended to say. So for example, so from what you've told so far, you are worried for the last 6 months, and you're also not sleeping well, and your job is at risk due to this. Is that correct? So after a minute or a couple of minutes, I'm just trying to give a summary so to make sure that they have said what they intended to say. Okay. So it also helps me as a doctor to form an idea of the narration so far. The same technique should be reflected in the OSCE exams too. Summation would be a very good way of developing rapport with the patient. Next one is facilitation. It's helping patients to continue the interview by providing both verbal as well as non-verbal encouragement. Okay. So like I mentioned before, approval nods, leaning forward slightly to express the interest, like the photograph I showed about one of the examiners earlier. So that will make them feel that they are interested in it. Saying yes and then asking more questions, say yeah and then go on. Okay. All these are small verbal and non-verbal encouragement, which informs the patient that the doctor is listening actively and encourages the flow of information from the patient. So facilitation should be done through both verbal and non-verbal encouragement. Redirection. This is a very important skill that we have to learn. Even in the real life, we have 10 minutes or 15 minutes to see a patient. Okay. So we should try to gently reorient the patient towards the topic of discussion. Okay. So the aim of redirecting the patient is to keep the patient on track and not let go of it. Okay. So for example, the patient says it is not good if one's parents are divorced even before one goes to school. That's right. But at that point in time, you want to ask something else. So as a doctor, you want to ask more information. So you can say, I would like to hear more about your parents. But first, let me get a picture of what's happening to you of late. So you wanted to know about the presenting problems, but the patient wants to talk about the past. A lot of people think that when they come to psychiatrists, they have to give a whole history, from the beginning, and that's what they're interested. But we have to just redirect the patient and tell them that you want to get a picture of what's happening to you of late, but would like to hear more about the parents or past history later. So that's one way of redirecting and also keeping the patient on track without offending them. Okay. Sometimes you can also interrupt. Let me say for a minute or two, if they are talking tangentially or going off track, you can always interrupt by saying that, can I just interrupt you there? Okay. What you're saying is something that is really important to you, and I'm glad to ask you more about it little later or at the end. But there are some other important questions that I would like to ask you before that. And I would like to ask you a little bit more about your current mood. So imagine you're seeing somebody who's depressed. So they may want to talk a lot of unwanted things, but we can always interrupt them and just say, you're going to ask about few things which you're talking now at the end, but you want to get some more information. You do it in a very non-offensive way that they don't get offended, but you're able to redirect the patient with careful interruption. Okay. So in this way, this is one important thing that we also have to learn on a routine basis. Limit setting. This is useful to manage time pressure, okay, both in practice and OSCE stations. So you have to set the limits cautiously, as overuse may detach the patient from the doctor. So you can always say, look, I'm running short of time. I've got 10-15 minutes to talk to you. I'm going to interrupt you as there are a few more important things that we need to cover today. Okay. So the motivation is setting limits to use your time effectively. Next important skill is reassurance. So part of the role of the psychiatric doctor is to install positive hope and also avoid or reduce despair. Okay. So things like, if you see somebody else who is depressed, then you can always say, the depression may be very difficult for you. I think it's very likely that with the proper treatment, you can get back to your job. So by doing so, we are installing positive hope for the patient. At the same time, false reassurance should be avoided. I heard people saying schizophrenia is completely curable, bipolar disorder is completely curable. So these kind of false reassurances should be avoided. But at the same time, you have to give the information in a digestible manner and also install positive hope through this reassurance. Validation and normalization. So validation helps to decrease a patient's sense of embarrassment about a particular feeling or behavior. It is generally done by quoting how it is normal for people to have different kinds of emotions, different kinds of reactions, behavior, etc. See, for example, if you're seeing someone who is self-harming behavior, they want to hurt themselves, okay? But you want to validate it or normalize it. How do you say this? Sometimes when people are very depressed, they think of hurting themselves. Has this been true for you? So we are telling the patient that these things are normal for somebody who is depressed, and we're also validating it. Okay. So those are helpful to develop rapport with the doctor, and they'll open up and they'll say whether it's true or not. So this is another important technique. Acknowledgement of affect. So you have to make a remark about patient's affect that can also facilitate disclosure. Okay. For example, if somebody is anxious, you can always say, I can see that you look really anxious when you're talking about those distressing voices. So that's one way of acknowledging their affect. So with auditory hallucination, they're distressed and anxious. We are acknowledging it. That will bring the patient to our side. Imagine you're seeing a manic patient. I can see that you're talking very quickly. Okay. This is one way of acknowledging their affect and making them understand that they're talking too fast. Then you can ask more questions like, what about your thoughts? Do you have thoughts, running thoughts? You have lots of thoughts coming into your mind. So you can ask more questions. So acknowledgement of affect is very important. Imagine you're seeing somebody who has got delirium tremens, having shaky hands. We can always comment, I can see that your hands are very shaky. Okay. That's one way of acknowledging their affect too. So these are different things which you can comment and acknowledge as part of the interview session. Advice. Many patients seek advice directly. It is acceptable to provide advice, but based on the understanding of the context. Premature advice can be obstructive than it's facilitative. For example, I would say we have to make it open. I really think it is best for you to consider ECT at this point in time. If I am you, I will give this a serious thought. So you talk about ECT, but if the patient's not made up their mind, they want your advice, then you can say, this is what I would do in this situation. You try to give this a serious thought. Statement of respect. Affirmative statements must be genuine and also appropriate, indicating respect and dignity, along with positive reinforcement. For example, you can say, you've been through a lot. I'm impressed at how you have hung in there. You must be a very strong person. So affirmative statements, they make the patient understand they're respected by the doctor, okay, and they're treated with dignity. So you can use these statements to make sure that they're respected. Partnering. Getting your patient on your side is really important. So the interview encourages the patient to ask questions and also express any concerns, encouraging teamwork. So I'm here to help with you. Let's just plan on working this together. So when you say that, you're partnering with the patient, improving the trust on you, and you're getting them on your side. Why questions? This is very important in psychiatry. I've noticed that many trainees in the first year don't ask why questions at all. These questions ask the patient to discover their own problems in a way. Okay. They're not useful when used to elicit information from a distressed patient. But when somebody is less distressed, you can always ask more why questions. Why do you keep staying up so late at night? When they say, I sleep only at 1 o'clock, the next question is, why do you keep staying up so late at night? Then they can open up and say, I was checking my emails, I was going through some Insta, things like that. So we can elaborate, we can ask more questions. So make sure you ask for why questions. That's very important. Compound questions must be avoided. Compound questions are multi-thematic questions where you add 2 or more questions in a single statement. Okay. When you add 2 or 3 questions, it can confuse a patient, which can lead to either response or no response at all. For example, say somebody is going on a vacation. Okay. You have to ask, do you take a vacation every year? That's one question. Second question is, are you able to relax when you take your vacation? These are 2 different questions, but people sometimes combine and say, do you take a vacation every year and are you able to relax? These are 2 different questions. So if the interview is simple, then the patient will be able to answer the questions. So compound questions should be avoided. Other common examples is people ask, how is your sleep and appetite? So sleep is something different, appetite is something different. Do you tend to take alcohol and drugs? So alcohol is different, drugs is different. So you should try to use separate questions to ask specific questions. Otherwise, they'll get confused and response may not be good. Okay. Pause and silence. This is really important for psychiatrists during our interview. Brief moments of pause can facilitate disclosure. Okay. Sometimes it is useful and allows free emotional expression for the patient. It relieves the patient's pressure when you're interviewing. They may feel more relaxed and they know that not every moment must be spent talking. Okay. That brief moments of pause would help them to think, give you more information. At the same time, it can also make you feel more relaxed. And that pause is not only helpful for the patient, even for us. It gives us some thinking time to ask the relevant questions and get the right information from the patient. Okay. People say things like, okay, fine. Actually, it should be used in the right context. For example, when somebody is saying, I'm feeling suicidal, you can't say, okay, you can't say fine in order to close your gaps in memory. Okay, that should be avoided because they're not okay. They're not fine. Instead, you can say, I see. I hear what you're saying. Then you take a brief pause for a couple of seconds. That's the way to do it, but not saying things like, okay, fine, these kind of things. Okay. And frame the questions very well. Otherwise, it could be misconstrued. So when we practice psychiatry, we have to learn how to ask questions for depression, psychosis, mania, alcoholism, drugs. So for each specialty, you should know how to frame the question and ask the right questions in a way that they can understand. Okay? Don't ask questions bluntly. Some people just ask questions bluntly. Generous preamble will help. For example, people ask bluntly, like, do you hear any voices? That can be very off-putting for the patient. Okay? So in my practice, I ask them, sometimes when people are distressed, people may hear voices when there is nobody else around them. Have you had any such experiences recently? So when you give the generous preamble, then you'll prepare the patient and help them to engage. So these are all important interview techniques which you have to practice. Be an active listener in terms of interview skills. So what is active listening skills? Active listening skills involve picking up cues. Okay? Patient will give you cues. In the exam, role plays will give you cues. When you pick up, your role is to listen actively, pick up the cues, and then you have to probe into different areas. I'll give you just one example. For example, the patient says, you're part of it. You know, you all do. Can't you hear it? I would say, hear what? That's the cue. Hear them. What do you mean by hear them? The police, they are after me. The doctor, after you. Yes, and you're on it as well. Why do you say I'm on it? In what sense? Patient says, you know, it's because of what I did. Doctor, what did you do? Yeah, when I found out about the terrorists. So you just use those cues to elaborate and ask more probe questions. That is what is called as active listening skills. So in the exam, you're not going to have a role player who's going to give you all the information. Similarly, the real life patient is not going to give you all the information. You have to use probe questions to dig deeper and get the information. Empathy. This is a very basic skill that we all should have. Use empathic statements during your interview wherever it is necessary. But when you use empathic statements, you have to invest them with genuine emotions in your face and in your tone of voice. Recently, you had your family member died recently. I'm really sorry to hear that. Okay, so you have to stop there, use empathic statements and invest them with genuine emotions. When there's lack of empathy, then the interview will be not good. Missed opportunities in empathy is also considered as an area of concern in OSCE kind of exams. Okay. Take a history. If the task says history, I always expect my trainees to get me a story. The term history means at the end of the discussion, I have to get a story from my juniors about what the patient is going through. If I'm not able to get a story, that means they have not taken a history. So always remember, whenever you have to take a history, you have to get a story from the patient. Exploring signs and symptoms competently. Okay. So in every task, range and depth of coverage should be very good. Okay. You're not a final year trainee. When you're exploring history, you have to explore in detail. When you're exploring psychopathology, you have to explore them in detail. For example, say you're eliciting delusions of persecution. I always remember this 4 E's. You elicit, you explore further, you get explanation from the patient, you assess effects and coping. All these 4 E's should be completed. For example, when they say that there is somebody else doing black magic on you, then I will ask them, who do you think is doing black magic on you? Why do you think they should do black magic on you? How do you know that they're doing black magic on you? What is the evidence to show that they're doing black magic on you? Okay. Can you just give me some explanation as to what is going on? So when we ask these questions, they will open up and give more and more information. Then we have to ask for the effects and coping. I'm sure all these black magic issues may cause you a lot of distress. You must be really upset about it. That's one of the way you express empathy and see how the patient is coping. And lastly, assess the degree of conviction. How do you know somebody is delusional? You have to ask questions. How sure are you about this? Are you 100% sure that there is someone doing black magic on you? Could this be imagination in your mind? Could this be your mind playing tricks? So you have to assess the degree of conviction. So when you elicit for delusions, make sure that you explore the psychopathology in detail in practice and also in the real exams. So examiners won't just pass you by taking a very detailed, very superficial psychopathology. Similarly, hallucinations. People ask about just modality of hallucination. Is it auditory or visual? But you have to ask for the modality of hallucinations. You have to ask for the source of hallucinations. Is this true hallucination? Is it pseudo hallucination? What is the timing of the hallucination? When does it occur? What is the content of the hallucination? By verbatim, you can collect the content of the hallucinations, the reality with which they are experienced. Okay. We have to differentiate whether it is second-person hallucination or third-person hallucination. We have to differentiate whether it's command hallucinations or running commentary hallucinations. Okay. And with all these hallucinatory experiences, how are they coping? It must be very stressful or distressing for them. We have to ask for coping. So when you ask all these questions in a psychopathology, only then the part of hallucinations could be properly completed. Okay. So what's happening now is people are in an autopilot mode. People have the checklist. So they ask 1 or 2 delusions, 1 or 2 hallucinations, they run through. But that kind of checklist should be stopped. We should try to go with the flow, okay, and try to take a fluent interview with good structure in mind. So always make sure that you switch off the autopilot mode. Also, you should try to abandon a rigid approach. In some situations, patient may want to ask you something else. You may want to talk about schizophrenia, but a mother or a father wants to know about the prognosis of schizophrenia. In those situations, it's better to address their concerns first. Okay. Patients, family members' concerns, ideas, expectations, that should be addressed first while we are doing the interviews. If you're giving explanations, always ask the patient, what is their understanding? These days, people look in Google. Okay. We can always ask, what do you know about ECT? What do you know about CBT? What is your understanding? So they can talk about it and you can fill in the blanks. It saves time for you as well, but also you're trying to understand what they know already. Okay. Important thing in psychiatry is avoid long-winded explanation. It shouldn't seem like a lecture. Okay. In my practice, I always give 3 or 4 important sentences. That's it. That 3 or 4 information is a crucial information that they can take it on board. I don't try to give a long lecture for them. I try to keep my explanation brief, concise, giving as much information as possible in few words and keep it very simple. Okay. So that's how we should do it. And when you give information, you personalize the answers. The answer should be tailored to the patient in front of you. So you can always say, the boy, John, he's hearing voices when there's nobody else around them. He has become more suspicious recently. He thinks that people are talking about him. John is not sleeping well recently. John is not going to school. He's becoming aggressive towards you and your husband. So all these symptoms are suggestive of a condition called as psychosis. And this has been ongoing for a long period of time. And we think he already had similar issues 2 years ago, and he also had treatment. So I think this could be a condition called as schizophrenia. And then you explain it. So you have to personalize the answers. Sometimes people just give, what is schizophrenia? They give textbook information. Instead of giving textbook information, you use the information you gathered from the patient, personalize the answers, and tailor them according to the patient in front of you or the carer in front of you. That's very important. Okay. Avoid using complicated medical terms. People don't like jargons. Unless it is very necessary, try to avoid medical terms. But when you're talking to professionals, you can use medical terms. Say you're talking to another consultant, another doctor colleague, you can use medical terms. Never give false information. Okay. So if you don't know something, you can always say that I don't have the information right now with me. I will look it up and get back to you later. But giving wrong information, inaccurate information, misleading information makes them lose trust on you. So be honest and trustworthy while you're sharing the information. Okay. And risk assessments, you also have to do risk assessment as part of bread and butter of psychiatry. Again, risk assessments should be very structured. Whenever you think of risk assessments, you have to think of past, present, and future. If you're seeing a suicidal patient, you have to ask about past history of deliberate self-harm, past history of suicide, current, present suicidal thoughts. What about the future? When they go home, will they try to harm themselves? Have they got any other plans to harm in the future? So similarly, for sexual violence, violent episodes, you have to have the structure in mind like past, present, and future. So make sure that your risk assessments are appropriate. Similarly, when you're eliciting something very risky in the middle of the interview, you should not just move on. If a patient talks about some suicidal ideation, you shouldn't say that I can't go on anymore. A patient says, I can't do it. I'm really suicidal and depressed. You can't just jump. Okay. You have to just stop there and try to explore them. Okay. So this is something that people do. So don't make these mistakes during risk assessments. Then ending the interview. Do not interview till the last second and say time is up. Last 1 minute is very important. Okay. Try to summarize the information. So when I talk to the patient, when I get the history, I always tell the patient, okay, let me give a short summary of what you mentioned. Let me get my thoughts together. And then you give a summary of the patient. Sometimes if you finish early, you can recap. Reflective listening would really help. So if you finish early, you can reflect back on what you've covered. For example, you have told me how your mood has been low for some time and how your sleep and appetite might be affecting you. It sounds as though you've already really been struggling with your work and that you can't be bothered with things. I think I'm correct in thinking that you haven't enjoyed anything recently. Is there anything that we haven't talked about which you feel is important? So you're giving a summary, and then you're also giving them an opportunity to demonstrate reflective listening. So that will really help. And sometimes you can ask the patient, have I missed anything during our interview? Do you have any specific questions that you want to ask me today? I'm quite happy to answer them. So by doing so, your interview will be more complete. Even the last minute, patients may ask some important information or important questions, or they can share something really important. Okay. Try to use better closing phrases. I realize that we haven't had as much time as I would like, but I hope I've been able to address some of your concerns. If it's okay with you, then I would like to meet you again in the next few days so that we can discuss this further. Thank you for your time. So if you say that, then the patient will know that doctor is available. Then you're going to meet up again with the doctor, and you can also share some of the concerns. Sometimes my patients come to a long list, and I tell them, I'll answer some of your questions. If you have some more questions, we can address it in the next session. So that's how we end it, not by saying, I won't answer these questions. Okay. So these are important. How are we with the timing?
Yeah, actually, we have completed the time, so we can wind up shortly.
Okay. So remaining and all is a physical examination. So in physical examination stations, you have to give clear instructions to the patient. You have to ask permission before you touch the patient. You have to ensure their privacy. If they're female patients, you have to ask for chaperone. You have to be very considerate and gentle while examining patients. I've seen many of my trainees, when they examine for thyroid, they try to throttle and strangulate their neck. When they look for eye signs, they try to poke their eyes. So you have to be really gentle when examining patients. That's what they look in the college exams. So different types of common physical examination stations tested are upper limb and lower limb CNS examination, cerebellar examinations, thyroid examination, cardiovascular examinations, checking for extrapyramidal side effects, asking for symptoms of akathisia, ECGs where there is QTC prolongation, a sinus tachycardia, infarct in a patient. So these are the repeated kind of physical examination stations. If you prepare well, you're more likely to pass those stations. And cognitive examination, usually they ask for a mini mental state examination, but usually they keep a patient who has some degree of hard of hearing, or they may have some visual impairment. So you try to complete the full mini mental state examination with giving them clear instructions. Sometimes the exam, they give patients who have some kind of frontal lobe deficits, and the task would say, please do relevant cognitive examination based on the information given above. So they may have frontal lobe symptoms. You have to look for frontal lobe testing. Then parietal lobe examination, similarly, they will give you some of the important symptoms, and you have to do parietal lobe examination. Etiology is commonly asked. When it comes to etiology, you have to remember 3 Ps: predisposing factors, precipitating factors, and perpetuating factors. Therefore, you have to ask relevant questions to check whether they have these predisposing factors, they have precipitating factors, and perpetuating factors for the illnesses. There's very standard things which are expected in the exams. So these are the things, I think. So we've got more slides. But management stations, when you come to management, you have to talk about pharmacological management. You also have to talk about psychosocial management. In Western countries, they expect the multidisciplinary team involvement. In India, when I practice, sometimes I feel lonely because you have to do everything. But in many of the Western countries, you have in hand, you have psychologists, social workers, community psychiatric nurses, OTs, and other disciplines working parallel with you. So for the right kind of cases, especially for old age cases, intellectual disability, and all these cases, they expect you to use other disciplines as well. Last slide, do not get intimidated by the actors or the role players. They're there to examine. Similarly, in the real life, don't get intimidated by the patients. Okay, we should learn how to take control of the patient. We should try to develop the trust and try to get them on our side. Okay, and don't argue with the patient, role players, as well as examiners. Okay, and when you're doing examination, don't get distracted by the conversation next door. Sometimes people may be doing something wrong. So I always tell people not to focus too much of what's happening in the other booths, other stations. Okay, and avoid watching examiners ticking boxes. This can be very misleading. Sometimes examiners would have passed you, but they think that they have failed at station. Mostly examiners would only mark after you leave the station. Okay, so it's very important. That's all really. So you can read all these things when you practice these things. In all these things, Oxford Handbook of Psychiatry, ICD-DSM for local guidelines in different countries, Royal College leaflets, and all these things, you have lots of information about how to pass in the OSCE exams. And in my course as well in SPMM, I have more than 200 to 250 stations about different areas of psychiatry where I use it for training and mock exams and courses as well. Okay. Thank you. If
Thank
you
you.
have time, can I just show one OSCE if you have time for 6 minutes?
So
Yes.
we are actually just
6 minutes, but
Okay.
it is really good. Please.
All right.
So
अलीम
should
लाइट
stop
ऑन
the
कर दे
recording?
अलीम लाइट ऑन कर दे
Sir, on करेंगे. So
Yes, sir.
should we stop the recording because is it a copyrighted thing? Because YouTube doesn't allow upload them.
No problem at all. I want other doctors,
Please keep it, Alim bhai.
junior doctors or doctors.
It will be really helpful because it will be in our website also, na?
Okay.
yes
I don't mind at all, sir.
Thank you so much.
thank you sir
Thank you for the extra time, but I hope you all enjoyed and found it useful.
It was a
All the
fantastic,
feedback
in
comes out.
fact, it is a mind-blowing presentation.
Okay. All right. Thank you, sir. Thank you for the feedback. Thank you all for the opportunity.
Sir, are we playing the video? Pratap sir, are we playing the video?
Don't think so. Sir, are we playing the video?
Yes, we are. If you wanted to, whoever wants to stay, you can watch it. I'm not going to talk. The video is going to talk.
I think on the safe side, should we pause it, sir? Alim bhai.
We are not able to.
You're not able to see the video, sir.
I'm not able to share the screen. Okay, I'm sharing it now. Here is the video. Can you see that?
Yes, yes. Now it's visible, sir.
yes sir it's visible
It's history taking for post-traumatic stress disorder.
Hello, Mr. Howard. My name is Dr. Durkin. I'm one of the psychiatrists working in the clinic today. I understand that your GP has asked you to come and talk to me today because you've been having some difficulties at work. Is that right?
Yeah, I've been struggling at work recently. Yeah.
Do you want to tell me a little bit more about what's been happening?
Well, I'm just getting into lots of sort of fights, I suppose,
And
arguments. Yeah.
can I ask what it is that you do? What's your work?
I'm an English teacher.
Okay, so is that quite a stressful job?
It can be sometimes, yeah. It's secondary school, so yeah, it's pretty full on.
Can you tell me a little bit more about the fights?
Well, it's just arguments, really. I just seem to be on edge all the time. I think I'm struggling, because I was off for a long time, and I don't know if I've come back too early or what, but I'm not. I'm not coping very well.
So it sounds like things are quite difficult. You said you're feeling irritable.
Yeah.
And getting into sort of fights, disputes with other people.
I am. Yeah.
Have other people commented to you that you seem a bit different?
Oh yeah, they have. Yeah, I mean, that's really not like me, to be honest. But I think I'm just struggling dealing with it all, because I've been off for such a long time.
Can I ask why it was that you've been off work?
Well, yeah, I was in an accident of some sort. Yeah.
And how long ago was that?
6 months or so. Yeah.
Is it quite difficult to talk about the accident?
Well, yeah, it is really it really shook me up, to be honest. I didn't know if I was going to get through it. I really thought that was it. I really thought the end had come. It really shook me up. Yeah.
So it sounds like it was really frightening what happened.
It was. It literally was. Your life. It's true what they say. Your life just goes. I really didn't think I'd see my wife or anything again. I really thought that was it. Yeah.
It might be hard, but can I ask a little bit more about the details of the accident?
Yeah. All right. Yeah.
Thank you. Can you tell me exactly what happened?
Well, I was going over a junction, and I think from what the police said, the person coming the other way had skipped a light, and they just went in to the side of me. I think I passed out or something. I can't remember much more than waking up in hospital, and I was in there for a while. Really, I was in quite a bad way.
How long were you in the hospital for?
I think I was in for about 6 weeks.
So quite a long time. And what physical injuries did you?
Oh, my leg and my arm were broken. Yeah.
How are they now?
And I'm all right now physically. I've had physio and stuff. And I say I was off for 6 months, so it was a while ago. But it kind of feels, because now I'm back at work, it feels like it wasn't that long ago.
Can I ask just a few other things? You were in the car on your own, is that right?
Yeah, I was just driving to work in the morning. Yeah.
So you were driving to work.
Yeah.
And do you know how the other person who was involved in the accident is?
I don't know what to say because I passed out. I don't really know.
So it sounds like it was a really traumatic incident for you.
Oh God, yeah, absolutely.
And you said you've been back to work for a couple of weeks, and things have actually been quite hard since you've been back at work.
I struggled to go back, to be honest with you. I really didn't want to go, if I'm honest.
Can I ask a few more things about how you've been at home? Who's at home with you?
Well, just me and my wife.
How have things been there?
Well, she has been supportive, but I think because it's been going on a long time, it is definitely taking its toll. Yeah.
Is it something you feel that you're able to talk about with her, what happened?
She does know initially, obviously, because I was in hospital for such a long time, but I don't want to keep talking about it. I don't really want to go there, to be honest.
So I can see it's really difficult to talk about what happened. Yeah. I'm wondering, some people, when they've been through really traumatic events, find that they sometimes have the experience of actually going back to what happened and almost reliving and re-experiencing it during the day.
Yeah.
And we often call that having a flashback. Is that something you've experienced?
Well, yeah, you don't intend to, but something will happen at work and it just brings it all back. Someone slams a door or drops something, it makes a noise. And it's literally like someone's pressed a video of that accident back to me, and I'm going through the whole thing again.
Is that happening all the time?
Oh yeah, every day.
Every day.
Something happened.
So that must be really difficult to cope with at work.
It is really, and it just makes me really, I can't settle.
You said you feel on edge, you're kind of startling when there's loud noises. You talked a little bit about feeling irritable with your colleagues, which is quite unlike you.
Yeah.
And do you feel anxious a lot of the time?
Oh yeah, I do. Yeah, I do.
Can you concentrate at work?
Not properly, no. No.
How is this affecting your sleep?
Well, it's a problem really, because I know when I go to sleep, I'm going to have to go through that whole experience of having that accident again, you see.
And are you having that when you're awake, or are you having it when you drift off to sleep as a nightmare?
No, it's a nightmare. Wake me
It's
up.
a nightmare.
Yeah, but I'm anticipating it happening because it's happening a lot.
And it's so disrupting.
nights.
Most nights you're
Yeah.
having that. So it must be really hard to deal with.
It's tough because I can't. Then I wake up and I'm tired. Then I'm worried about going to work, and it just never ends.
Can I ask, when you go to work, are you still driving to work?
Well, I have to really because of the location of the school and where I live.
Right.
Yeah.
How was it getting back in a car?
Oh, it was a struggle, to be honest with you. I mean, I think I had a panic attack. I could feel my heart racing and stuff, and I really didn't know what to do.
Felt very, very anxious at that
I
point.
did, yeah, I did, and I couldn't go my normal route.
So you avoid driving the way that you used to?
I know I won't go that way. No.
Do you avoid talking about what happened or watching anything on TV to do with car accidents, things like that?
Yeah, no, I won't watch. I don't want to watch the news or anything. So there's been an accident and stuff. It just brings it all back.
Well, thank you for telling me, because it must be hard to talk about it. Can I just move on a little bit to talk about your mood and how you're feeling in yourself?
Well, I don't feel right.
Okay.
I'm very worried about it all, to be honest. It does get me down. Yeah.
So if you feel a bit down, some people say actually they can feel quite numb and cut off from their emotions. Have you had that experience?
Kind of, because you do feel a bit like, I don't know, you just don't feel yourself, a little bit.
Are there things that you can still enjoy in your life?
I haven't really settled back into how I was before, no.
And have there ever been times when things have felt really, really difficult and you felt like you didn't really want to go on?
I think when I was in hospital, there were a couple of times where I thought, I don't know if me surviving that accident was the right thing. Yeah.
Well, I'm glad you came to see us, because I think there's a lot we can do to help. Just a couple more questions again in terms of thinking about coping. You said your partner's at home who you can talk to a little bit, but it's hard. Are there any other ways that you try and help yourself relax a little bit?
I just try and unwind a bit when I come home, really.
Okay, how do you try and do that?
Well, just pour a glass of wine and just try and forget about it all, really, and unwind, yeah. And
have you found that you're drinking more than you used to?
Well, I probably am, yeah.
And how much are you drinking at the moment?
I'm probably getting through maybe a bottle.
Are you worried about how much you're drinking?
Yes and no, really. I'm hoping when things settle down a bit, I'll go back to my old habits, maybe, I don't know.
Might be something that we can talk about again. And using any over-the-counter medication or anything to try and help you get to sleep, or any drugs?
No, I haven't done. No.
Have you ever seen a psychiatrist before?
No, first time.
Okay. And any other history of trauma or anything difficult in your life?
No, nothing at all.
So, Mr. Howard, thank you for telling me all of the information. I know it was difficult to talk about things.
Yeah.
The range of symptoms you were describing following on from the traumatic accident makes me think that you have something called post-traumatic stress disorder. Have you heard of that before?
I've heard about it in the army, yeah.
That's right. There's a lot that we can do to help people who find it difficult to move on after a traumatic event. And I'd like to get you back to clinic, perhaps with your wife, if you'd like to talk about the options further.
Yeah, okay, then I think she'd like to come in, yeah.
Great. See you again.
Thank you.
So that's the video.
Thank you so much, sir. It was very nice, wonderful presentation. It was just a revisit our JR days. So thank you for walk back in the memory lane. Sir, we are actually out of time totally. So I think we'll skip the questions. We'll go to the chairpersons. And then if possible, we can call you once again for a meeting. Questions are pending. Chairpersons, sir.
Hello.
Yes, sir. So you can stop the screen share. Yes, Rao, sir.
Hello. Okay. Of course, it is such a good learning experience how actually this OSCE works. we have a little modification of this in Indian setting, in the sense we have long cases, short cases, neuro cases. So also some oxy stations where specifically certain specific aspects related to maybe for some particular treatment technique and other related things. But this is a very good idea that comprehensively how this can be generated. Large number of people can be interviewed in a very structured and formal way, and in due course of time, I think even our country will be there to implement this. That means we should get ready with many of these things, because the range of advances and reforms that are coming, maybe this is also one of them. IPS has already done a great job in this particular area, and I think we should relook, see that we are in tune with a lot of things. Our own traditional system of doing exam and carrying on actually is one aspect of it. But in between, striking a balance between these two, I think that's what actually I can make a comment. Really good learning lessons, sir, and we are really grateful for such a wonderful presentation and enlightening discourse. Thank you very much.
Thank you, sir. Thank you all for patiently listening.
Thank you. Gautam, are you there? So please unmute.
You are muted, Gautam. Unmute. Again muted.
Thank you for excellent presentation throughout, and the video was really good. I think it is very much helpful, not only us, also the juniors, as I mentioned before. And this is the way forward, actually. We can think of in future, as Dr. T.S.S. Rao mentioned perfectly, we can think of our traditional methods and how we can incorporate this type of examinations in us. And one question to you. Usually in our clinical practice, what we do, there is a table in between the patient and the examiner and the psychiatrist, I mean, because it was told in our student life that there should be a safety. If the patient is violent, their minimum distance and they cannot reach you. What is your take regarding this?
See, this is a
Dr. Sripata.
This is a simulated exam, so we can't really replicate real life scenario fully.
Yes.
But they do have tables in these kind of aggressive patient stations, physical exam stations. There are some stations where they keep tables also, but it's usually rare.
And another thing, as Dr. T.S. Rao also mentioned, that in our traditional method of in our examination, in the seeing the case, long case or short case, we used to write on a paper. But here only we are just asking question. There is no writing notes or nothing else.
No, they do. They write. The real
they are
exam,
writing. In the real exam, they have to do.
Because anxiety, sometimes they might forget what they have discussed. So at the end of the 7th minute, sometimes people tend to forget. So to overcome the anxiety, they are usually given a notepad. So they write down.
Yeah. That's
it.
A
picture just to teach the trainees. So we didn't do that.
Thanks again. It is a really lovely session for learning to all of us.
And sir, this sir has presented this in a time of formative assessment, but equivalent tips are relevant for summative assessments here.
Yeah, true.
Excellent tips for I think for postgraduates, it's a very, very interesting webinar.
I mean, at the end of the day, different exams have got different styles and different positives and negatives. Again, OSCEs have some drawbacks, but overall it helps to assess very different areas in a structured way. And the uniformity can be maintained without any bias. That's all. Okay. Okay, sir. Thank you all.
Thank you. Thanks. Thank you so much.
Sir, Tufan sir, can you end the session, please?
Yeah. Thanks a lot, Dr. Pratap. Excellent session and a good learning experience for us all. And we are not practicing this type of OSCE. As Dr. Rao told, we have some session in OSCE, but it's not so elaborate. And And nothing of that sort was there earlier also. But it is a vision of the tomorrow, and it may have to be modified a little more to make up of some lapses, which must be knowing is there. And it must be our country friendly, so that it can be implemented in all the medical colleges. Thanks a lot for enlightening, and it should be incorporated type of teaching also, so that people can face it. And with this, I hand over to Dr. Amrit as his first for conclude the program. Amrit, you are here?
Thank you, sir. First of all, let me congratulate the entire Thursday Musings team. Achieving 250 episodes is unthinkable, undreamable also. What started out as maybe 13 episodes or 20 episodes, turning out to be 250, and being a benchmark in how you can conduct online classes or online courses, bringing the best is wonderful. And I think thank you, Dr. Tofan, sir, Dr. Aleem, Dr. Vishal, and Dr. Shobit. And we also started with Dr. Sazia and Dr. Rucha and Dr. Sharda also. It will be unfair not to take their name. And Torrent for constantly supporting it in the back. They have been the backbone. We have a great group of people who have been following us, who have been encouraging us, who have been egging us to do better and bring better things. Thank you, everybody. And this episode was also a great. We had more than 240, 250 participants. It was very engaging. It was eye-opening. We subtle, we always read PSC 9 when we were doing our exams. So this is something bigger, better, and I think it's the need of the hour. So thank you to Dr. Gautam Shah also, who has been a constant supporter. Dr. TSS sir, Dr. Savita madam could not attend because she had a sudden surgical procedure and she was under anesthesia, but she has recovered. And thank you, everybody. Thank you. Good night. Till another musings, the 2 to 51st one next week. Bye.
Good night.
Good
Thank
night,
you so much.
everyone.
Good night.
Bye-bye.
Thank you.
Thank you.
Good night, everybody.
Good night, sir. Sweet dreams.
Yes.
Dreams are always straight.
Dr. Lim, you have to close the meeting.